Hi, I'm Dr. Melissa Walton-Shirely. Thank you so much for joining us today. We're excited to be coming to you from New York, where we're attending a focus on women and cardiovascular disease. This special gathering, sponsored by the Mayo Clinic, is entitled In the Prime of Her Life. Today's panel discussion will focus on what troubles the 50-plus woman's heart. And I have with me Dr. Desvigne-Nickens of the NHLBI and Dr. Sharon Hayes of the Mayo Clinic for this very important discussion. I'd just like to compliment you both for coming today and for organizing this, Sharon. This has been a fabulous meeting, one of the best I've ever had the privilege to attend. And I think out of it will come very important information that may change the way that we approach women with heart disease. So I'll just dive right into it. We had a brief discussion earlier about why women do worse than men who have heart disease. So Sharon, if you don't mind to address that.
Well, we know that for a lot of things, particularly interventions like bypass surgery and interventions, women have not had as good outcomes, whether it's 30-day outcomes or longer-term outcomes, as men. And some of that probably has to do with some sex differences, some pathophysiologic sex differences that we don't completely understand yet. We can talk about what we need to know for that later, but the other part is undertreatment. Women are diagnosed later in their disease, they get less intensive treatment, even things like aspirin after a heart attack, which the barriers are low because of no prescription needed and low cost. So that certainly plays into that.
So Patrice, do we really know what to do for women? Why is it that women are not included in large-scale trials? Are we too busy to participate, or are we just really not invited?
Well, I don't think either not being invited or too busy are sufficient reasons. The fact is that in federally funded research, it's required that appropriate numbers of women are enrolled. Unfortunately, we still today have trials that have difficulty enrolling women, even when they're trying to target to meet these federally required percentages. There are many reasons for that. Some of them have to do with real barriers for women, such as transportation issues. Women are often caretakers in the family and have a difficult time finding time to participate in trials. Insurance issues, family issues. But we try to overcome these by introducing incentives, providing transportation, making hours available so that women can participate. But I think it's really important that if we are going to really have the best outcomes for women, that women participate as research partners, as participants in trials. That would go a long way in improving outcomes.
But I also think some of it is women have not taken ownership of this disease. And so when they're looking, one, they may not be aware that it's important for women to be included in any kind of clinical trial, but I think particularly for heart disease, they're still perceiving it as, well, if you do the research on men, or why should I participate? And I think that's a message is, taking ownership. Volunteering for this trial may help your sister, your daughter, your mother, and it can be a very minor thing. And I think that we see that as well, in addition to the inviting in and overcoming barriers. And there's some things about these trials that actually inadvertently exclude women, perhaps it's more ageism. So when I was in early training in the TIMI trials, where the upper age limit was 65, and we know that women tend to have heart attacks later, so we didn't include men over 65 either, but there were a whole lot more women in that cohort, so we missed out on understanding them.
Yeah, absolutely. There are gender differences in presentation, age. There are other issues as well, sometimes symptoms, even fats, lipids in the bloods. There are different cutoffs by gender. These are all issues that come into play. But I think Sharon may have hit on the most appropriate message, because this is one for which women are in charge. Heart disease is the most important killer. It kills more women than men, and this is true since 1984. And so trials having to do with heart disease should be, like number one priority, something that we need to be involved with, because we want to know what to do best for our heart health.
You know, it really struck me, the panel that we just watched with those patients, the female patients, that some of them had a misdiagnosis or they couldn't get anyone to listen to them. I think, Patrice, you were talking in general about women who've actually had a diagnosis that was missed and how poorly they fare and their outcomes are so bad. Can you speak to the patient with the misdiagnosis?
Yeah, so fortunately misdiagnoses are small, but nevertheless when that happens, the outcomes are routinely poor. Again, while this awareness is important for everyone, and certainly healthcare providers, emergency room doctors, etc., all benefit by having a better understanding of how gender affects presentation, symptoms, even description of pain. Having said that, women, all of us, all people, but women in particular, are in tune with their bodies, know signs and symptoms for a heart attack or heart disease, and you should share that with your physician. It's important to say, I think this may be my heart. I have making sure that the treating physician is aware of the family history, risk factors, etc. These can all be things that can make the difference of that the primary diagnosis is heart and not secondary. Confusing GI symptoms, which can be
menopausal or panic attack or anxiety.
Yes, I have a favorite patient story where this was a young woman, 40 years old, presents to the emergency room with signs and symptoms, might be a heart attack. Her doctor said, look, this could be a heart attack, but it could be a lot of things, indigestion, gallbladder, very common. We'll look into this. And the woman responded, well, I had my gallbladder taken out last year. I think you should focus on that heart attack thing. And she, in fact, was having a heart attack.
Very good. She was her own best advocate.
Yes.
So, Sharon, can you help us, train us in this short period of time we have here to tell cardiologists how to spend the best amount of time with their female patient that comes in and says, I don't have any heart trouble that I know of, but my dad had heart disease, my brother's had a stent. I mean, what type of dialogue should we have with that patient? And what should we insist upon the patient do with regard to testing to try to help them?
Well, I think that it is asking those questions. It's one, asking the same kinds of questions of the woman that comes into your office about her heart risk, because that's the first thing you do is assess the global risk, and that does include her habits. And I think it's important if she says, I have 5 family members with heart disease, well, did they all smoke? I mean, that's an important piece, because if she doesn't, versus it's a pretty good predictor that she might be a smoker as well, to dialogue on that. And depending on the age of the family members, but then you need to check her blood pressure and her lipids, and if you need to, plug it into the Framingham equation. What we found in research several years ago was that given 2 fictitional patients with male and female with identical Framingham risk score, physicians downgraded the woman's risk. So they said, okay, I see the numbers, it's 8% for both of them, but she's a woman, so that must not be true. I mean, that's what we presume. So I think it really is following the guidelines that we have that can help us. But women are different. They're less likely to have the blockage, or a discrete stenosis of atherosclerosis, but their microvascular system may be very dysfunctional, which is accounting for their symptoms. So I think broadening those diagnostic possibilities, particularly when instead of writing her off said false positive stress test because her coronaries were normal.
I want to talk to you a little bit about stress, too, and the female patient. 20 years ago, someone asked me, will stress kill you? And I remember very well, and I'm ashamed to say that I said, well, I think you have to have some heart trouble first before stress is going to do anything bad to you. Well,
we know that's not true.
Now we know that's really not true. But apical ballooning in particular, the studies that were presented earlier this year about apical ballooning, and you could actually, I think someone mentioned today, utilizing the DASH diet, it improved your vasoreactivity. So talk to me a little bit about how you advised your patients to avoid stress and how to handle stress. Tell me about that and what role it plays in cardiovascular disease.
So there are several really good studies that show that stress reduction is an important intervention to reduce risks. Women tend to internalize, I think, the feeling that as caretakers, that there's no one is going to give the same attention, same priority, and do the job as well as women. And so we are our worst protectors because we're unwilling to give up. And so we feel the tension, but we feel that the responsibilities are ours, and we meet those responsibilities rather than taking care of ourselves. So I think that stress reduction for women is a really difficult thing. So exercise is effective, is important for heart fitness, but it is also a good source for reducing stress. There are pleasurable activities. There are meditations, yoga, Pilates. These are all things that are very excellent, and stress reduction is associated with an appropriate reduction in risk.
Well, and I think I certainly have, in my practice over the past decade, changed my emphasis on stress reduction. Because even back when I was in training, we talked about stress reduction classes, but I think it was the perception, you have so much job stress. It was very much focused on the kind of external stress that men had. And now when you really think about it, and some of the accumulating data, so I sort of push people to become more mindful. I mean, mindful-based meditation or just being mindful has some very beneficial effects. It's kind of like biofeedback. You can lower blood pressure and lower stress levels. Finding pleasurable things, I think I'm much more likely today to suggest something very specific, not just reducing stress, but why don't you, you're already fit, why don't you start going to yoga classes too?
Right,
don't just
sure.
go to the cardio classes.
That's right.
And looking for things that people can have some quiet and introspective time. The benefits are there. Exercise has been shown for depressed individuals, for depressed women, to be as effective as single drug antidepressant.
Sure.
SSRI.
I think part of our Go Red for Women campaign should probably include Just Say No to Overextending Yourself campaign too as well, because that's a large source of our stress.
Absolutely.
Mindful no.
Yes,
Exactly
a
right.
mindful no. And again, you use the term stress, but actually depression is is an important risk and is perhaps an important manifestation of stress. So to be healthy is to be able to love and to work. And the work part is physical, and I think we understand that, but the to love part is very complex. And it means that we are stress-free, we enjoy our relationships, our whatever the jobs are, multiple or single, but we're free to enjoy that, and that part is very important to our overall health.
And very elusive for many people.
Oh, absolutely. And I think part of our stress in the past 5 years has been affordability of good health care. So if we go to our physician, how can we get the most bang for our cardiovascular buck for prevention? If you go to your physician, what should you ask that physician to do for you? Let's say at age 50, you're newly menopausal. What do you want to check? What do you want to do to make sure that you are, fit?
Yeah, let me
Well, I think we know that we want to do age 50 or perimenopausal is a great time to address women's health. We have many opportunities as cardiologists because many women have become more attuned, whether they're having menopausal symptoms or whatever, and they're looking at their age, the sandwich generation. They want to be healthy to be able to care for aging parents. So it really is an opportune time that we should take advantage of. They should take advantage of us, but we should be taking advantage of this time to modify behavior. So I think knowing what lipids are and digging a little bit deeper. I often, particularly in that individual who doesn't have a lot of other standard risk factors but has a very strong family history, might, in addition to a standard lipid panel and glucose, check a lipoprotein A, because that may up my ante in terms of risk modification recommendations. I think that's a great time to get that counseling visit and to address other things. And if you identify, and I think this is the pay it forward which really resonates with women, if you do identify hyperlipidemia, hypertension in that 50-year-old woman, then she should have her children checked.
Absolutely.
You make sure you talk to because a lot of at that age their child may not have insurance.
Sure.
But but maybe, and they should see a doctor about that elevated blood pressure.
The first postmenopausal visit that I have with my patient, I'm now introducing them to calcium scoring. How do you feel about calcium scoring?
Calcium scoring, I talk to them about it. If they have risk markers, I do not use it as a screening test for all comers. But that individual who has several risk factors, and particularly potent risk factors, I think it, and who wants to know, if it will change what I would recommend to the patient, then I think it's a reasonable test for that intermediate risk. So they've got elevated lipids and they've got a little borderline hypertension. They don't really want to go on medication. And if I thought that they were clear, I'd say, yeah, let's try diet and lifestyle for 6 months. On the other hand, if they had a very high calcium score, it would be a statin right there.
Sure.
So I use it as, but not as a screening test.
I understand. Patrice, how can we make prevention sexy in America?
Oh, if I knew the answer to that question.
Maybe we could spend as much money as the fast food manufacturers do on advertising.
Yes, but this, it's such a serious problem. We have to be serious in responding to that. So of course the obvious payoff is longer, healthier lives free of heart disease. That should ring true for women in their prime. Let me just say that women over 55, 1 in 6 have cardiovascular disease. 10 years earlier than that, that number is 1 in 19. So you've tripled your risk just in age. I didn't speak specifically menopause and the other risk factors, but that is an overall statistic. So you are at the highest risk of having a cardiovascular event. Gosh, things that are simple are not necessarily easy, but just because it seems so simple doesn't mean that it's not effective. So when you remove risk factors, you can reduce your risk for heart disease by 80%. So I can only give you information to empower, but there is plenty, so much compelling evidence of the benefit of controlling risk factors, and what the poor outcomes that occur if you don't. So I hope people that are listening. But I should also say, women are so good at taking care of their husbands and their children. Well, you can't do that if you're not alive, and you don't do that as well if you are disabled because of heart disease. So, so it's only information, but simple things can be effective. Eating well, being physically active, those are simple things, and when we do them for ourselves, we do them for our families and Americans, for public health benefits. Maintaining a normal weight is more difficult, but if you exercise, the weight comes. You eat well, the weight will be there. We're not talking about some svelte, modelly figure. If you exercise, the weight that that results from that, even without an actual change in the scale, there's significant benefits. So these are things you feel better, you look better, you'll live longer.
Is that sexy?
Boy, I think that's pretty sexy.
I think that's really sexy. Sharon, your patients obviously adore you. Some of those patients on the panel, I could tell, really were grateful to you. So can you give me a little bit of the Dr. Sharon Hayes flavor of what you tell your patients who say, what can I do? What type of preventative measures should I implement? Just tell me how you would talk to me if I were your patient.
Well, I will, and this is something that I learned as I matured as a physician, that what I think the patient is there, because I've read their chart and I see they have heart disease, and I think, well, that's why they're here in my office. I'm a cardiologist, and the reason that they're in my office. So actually the first thing that's out of my mouth in virtually every patient visit is, what can I do for you today? And I get surprising answers, and it's very helpful because that actually sets the stage for if the first thing out of the mouth, I want to get off as many medications that I have, and they have an ejection fraction of 30%, then my job is to talk about how grateful they should be to the other doctor that put them on those medications because they're saving their life, versus, I've got chest pain. And so I think how I start actually has helped me a lot as grow as a physician, because I then meet the patient where they are. And I think that's the biggest thing. Patients who are unhappy with their doctors they're unhappy because they do not feel heard or listened to. And so if I do nothing else, even if I am not necessarily the smartest doctor, I refer them to somebody else because I can't figure out what they have, I think it is the listening part.
Absolutely, and I think communication is the pervasive necessity that will help us to advocate for all of our patients that really need our help. And I can't thank you. So I just really appreciate the program today and the opportunity to talk with you, because we really revere you and appreciate all that you contribute to our medical community. So thank you very much for joining us today on theheart.org.